Good morning, good evening, good afternoon, everyone, depending upon where you are. And we have some international fellow here. So, first of all, let me welcome Dr. Shankar Prinja, who has kindly agreed to speak in this dialogue. But before I hand over to Dr. Shankar, this is really a proud moment for Foundation for People-centric Health System. August is a special month. It's special because this was the month in 2021 when this Foundation for People-centric Health System started. So we are completing 2 years. And on completion of 2 years, we are organizing this first dialogue series. We like dialogue, but this is a special dialogue. We want to focus upon a topic which generate a lot of interest. And everyone is keen to know about health financing, health economics. But they rarely get an expert or experts who can give them some insight and understanding. So what we thought, let's utilize some of the India's best resources on health financing, health economics, and bring them together. So bringing them together was not possible in one day. So what we decided that we will do a dialogue, and in a form of 3 separate dialogues as part of the FPHS dialogue Health 2023 and focus upon health financing. So today is the first dialogue as part of 3-part dialogue series. Then second one will happen on 23rd of August. Dr. Rupali Goenka will be speaker for that. And then third one will be on 25th of August. Dr. Indranil Mukhopadhyay will be talking. And what we have curated 3 different topics. One, Dr. Prinja will be talking about today principles or concept of health financing and of course health economics. Then in the second dialogue, we will focus upon out-of-pocket expenditure and government spending on health. And third dialogue will focus upon how to apply those principles, the theory and some of the concepts into a program implementation or for the universal health coverage principle. So it's kind of, we will move, like we will blend all 3, like a principle, theory, and practice as a part of the 3 dialogues. We want to keep this very interactive. So what we are doing, we will focus upon we will give speakers the opportunity to speak and talk about present their ideas. And then second part, we want to make it interactive in the sense that the audience here in this call, but also through our social media, if there are questions, I would pose those questions to Dr. Prinja and then try to hear his listen to his ideas or his responses or reflection on those questions. So this dialogue is for around 1 hour. We would invite first Dr. Prinja to speak for 15 to 20 minutes or maybe 25 minutes, and then remaining half we will utilize for question and answers. With this background, let me once again thank Dr. Prinja for joining and agreeing to speak on this topic. I hand over to Dr. Shankar for his presentation. Then I'll come back again after, like, once he finishes his presentation, and we'll take questions. And the fellows who are already here on this call, please be ready with your questions. You can raise your hand and just I'll indicate that, okay, you can ask your question. So fellows' question, you can ask directly Dr. Prinja. Remaining questions, I'll pose to Dr. Prinja. Over to you, Dr. Shankar.
Sure. Thank you so much, Dr. Chantakant, and it's a pleasure to be here. It's an honor to have been invited on this forum. So I'll try and share my screen. And I must admit that I was under the impression that perhaps the 3 of us would be together, the 3 speakers. So I tried to keep my content relatively much more limited because I thought that we might need space for other speakers to also share their views. So I have about 9 or 10 slides only. I don't have too much. So I'll basically try and open up the discussion to basically emphasize the need to understand healthcare financing. And I'm restricting the entire talk and discussion around healthcare financing only because I was given the topic on healthcare financing, whereas the health economics may have certain areas of application which may go beyond financing per se. So I'm going to restrict right now on only the healthcare financing aspects. And what I'm going to cover today in these next about 15 minutes is the need to, why do we need to understand healthcare financing? So for all of us who are healthcare professionals, either public health professionals or delivering clinical care or engaging in any kind of a activity which eventually aims to improve the overall health of the population, why should we be bothered about healthcare financing is what I would like to emphasize in the first 3 or 4 slides. And then I'll try to explain what exactly do we mean by the functions of healthcare financing and what does the financing function of health system actually involve. Because as a layperson, sometimes we are made to believe that what we mean by financing is basically budgeting. And preparing a budget is what is the function of a person who deals with financing. And that's what, and a lot of times we also try and sometimes have a notion that perhaps healthcare financing is something like accounting of healthcare resources or something like that. But I think it goes much beyond that. And this is what I'll try to emphasize, not go into details, but just to emphasize. And then I'll give a little bit more details, but not a kind of a theory lecture, but we'll try rather to keep more time for subsequent discussion. So just to set the context that why should we as healthcare professionals, public health professionals, or anybody working in the field of healthcare be interested in learning or at least understanding what financing means. This is a framework that the WHO used long time back, around more than 20 years back, to define what a health system is. And this was rather one of the earliest attempts towards actually defining what are the boundaries of a health system, what exactly constitutes a health system, and what is something that goes beyond a health system. And as part of this attempt, they also created a lot of performance measurement frameworks for health system. So in order to do that, they basically defined what are the functions, which are the ones that are listed in yellow. And they also identified what are the eventual outcomes or objectives that we want to achieve for the health system. So basically, we want to achieve the highest level of health for our population through delivery of services which are responsive to their needs, of a good quality, respectful, dignified manner they are delivered, and in a manner that does not impose too much of financial hardship. And there is a fair financial contribution by people who have to finance that healthcare. And in order to meet these objectives, you have to serve certain functions. The health system has to deliver certain functions, which involves eventually delivering the services. But to deliver the services, you have to create resources. This could be human resources. This could be resources in terms of time, supplies, etc. But eventually, a lot of these resources requires money. And so you have financing as one of the important functions. And to manage this entire system, you need a governance function or stewardship role that the healthcare managers need to fulfill. And as a result, these become the functions of the health system. This is a very, very simplified, non-convoluted relationship between these functions and the outcomes. But if you see a much more detailed one, then you will realize that the understanding is much more convoluted. The arrows are much more crisscrossing each other, etc. But what I want to, for this lecture, what I wanted to highlight was that as you can look at it, one of the functions of the healthcare system and one of the objectives of what we want to achieve through the health system is clearly related to how you finance your healthcare system. So financing becomes an important function, and eventually one of the objectives is also linked to how you finance your health system. So for both those who are involved in delivering or managing the health system and in order to improve the health system, it is important to understand this whole concept of healthcare financing. Moving forward to our more recent understanding, where we have been hearing this rhetoric of universal health coverage and also a lot of aspirational commitments towards that as well, where all of us, I'm sure, would have seen this cube, where one of the axes of this cube again is financial protection. So whenever you have to think of how you measure universal health coverage, this cube comes to your mind. And within this cube, again, one of the functions is one of the attributes is financial risk protection. So again, the aspect of how you finance healthcare services, how much money do people have to pay, how much hardship does it impose, eventually it gets imbibed within the concept of universal health coverage. So again, this raises importance, and this is something that also gets translated into the measurement framework of our SDG agenda, where we want to the achievement of universal access to healthcare services becomes one of the foremost goal, and this financial risk protection measurement is one of the measurable targets and achievements. And then again, putting into context, another important development that is taking place, not just in India, but in a lot of other countries, is that we are trying to move towards a system where we are seeing a growth of demand side financing instruments. And the example that I show here is simply of one type of demand side financing instrument, which is your publicly funded health insurance programs. And this is not just at the national level, this is also at the state level as well. But there are applications of these demand side financing systems at even in the public health system, where we are talking about conditional cash transfers, or we are talking of some kind of voucher schemes. All of these where money which is being paid to the healthcare providers is being, is following the patient. It is not being paid to create the supply of healthcare services. So again, this context also makes it essential for people working in the health system to learn about the principles of healthcare financing. And we see gradually that this coverage of healthcare services is gradually increasing. This is one of the recent figures from NSSO, where we do see that there is an increase in the proportion of people who are having any form of a healthcare insurance. So again, this necessitates us to understand what the principles of insurance, risk pooling, and financing are. Now, moving from this set of earlier slides, where I was trying to basically reiterate point and drive home the message that there is a need for understanding financing. This is a slide which tries to give a relatively more simplistic understanding of what are the functions of healthcare financing. And this is a framework that was given way back again around the beginning of 2000, and then it has been modified over several years by layering it with different complexities that are involved in it. And as you can see, the function of financing is not just creating resources or collecting funds, but it is also how you pool these resources. And there can be various ways of pooling resources, whether you pool it at the level of, a local, a region or a state, or at the national level, whether you want to introduce some kind of systems of taxes which are earmarked, or whether you want to introduce it as a general revenue, etc. And then more importantly, the function of financing also includes the activity of purchasing of healthcare services. And that's a very, very fundamental recent reform that is coming into picture in various countries, where we're trying to move towards some form of strategic purchasing, because we recognize that we have to improve the efficiency of the healthcare services. We want to also set the right kind of incentives for our providers to also function, and also the right kind of signals in the market for the beneficiaries or the clients also to access healthcare services. And finally, while the providers provide healthcare services, however, you have to, as healthcare managers, pay the providers for the services that they are delivering. So payment and developing systems of provider payment, again, ensuring that the broader goals of the health systems, the efficiency, equity, access, quality, etc., are ensured, again, becomes an important function of financing. So financing is not just limited to preparation of a budget. It is not only limited to just collection of money, but it also involves decisions around pooling of resources, those resources that you have collected. It also has decisions related to purchasing of healthcare services, and finally developing systems of provider payment. And for each of these functions, there is an interface with the entire population at large, where you have to make decisions about entitlement, contributions, coverage, choice, the degree to which you want to introduce some kind of cost sharing, whether at the demand side or at the supply side. And there is also an interface at all these different points with the payer of healthcare services or the person who is providing the overall stewardship or governance role, in order to set the rules of the game, to have some kind of regulatory frameworks, and also for the overall provision of information. So as you can see that it's a relatively much more complex thing than what we may sometimes take it as in a loose sense. And moving into each of these different functions, and this is just to show you a glimpse of it, I think there are various mechanisms to even think about when we start to talk about the collection of resources. So even when you look at collection of resources, which was the first bottom stage of the overall pyramid, you can have various mechanisms of collecting resources, and based on which your overall financing system might be then given a certain label. So it could be a tax-based system where you levy a certain charge, a certain contribution on the income of individuals, or it could be a social insurance system, so for healthcare, where you try to charge a certain proportion of the wage as a mandatory contribution towards providing healthcare. Or you could have voluntary private insurance, where the fundamentals of the determination of your contribution is not linked to your ability to pay, but which is linked to your risk of falling ill. So the entire methodology changes when you start to talk about voluntary private insurance. And this fundamental difference between tax and social insurance versus a private insurance raises the other deficiencies, gaps, or lacunae that we often hear about any kind of a risk pooling systems, whether it's adverse selection, whether it is moral hazard, etc., which may be, of course, be evident even in these systems of social insurance and tax-based funding arrangements. But these get further magnified in a voluntary private insurance, where systems of adverse selection also start to play their role. Or then you could have certain systems of small-scale experiments of financing, which may take the form of community-based insurance systems. Or if nothing of this is possible, then you let people pay out of pocket. So, which is perhaps most regressive mechanism of financing healthcare. So just to again highlight that there are complexities even when we start to think about the first step, which is collection of revenue and its pooling. And the devil lies in the details. So even when you talk about taxation, it's not a very straightforward answer that you're looking at tax as one single homogeneous entity of financing healthcare. But even when you look at tax as a method of financing healthcare, there could be various subsequent stratifiers that you may introduce, which may eventually affect the overall outcome. So what is the type of tax that you are using for financing, whether it is a direct tax or an indirect tax? At what level are you trying to pool your resources through tax money? Is it at the national or the local? Or in what way are you, initially collecting it? Does it go to a general revenue? Or is it simply assigned for a specific purpose? That means it's an earmarked or a hypothecated tax. And each one of these further stratifications has a significant impact on what's the degree of the vertical equity that you are likely to achieve with this particular mechanism of financing, or what are the subsequent type of efficiency incentives that you may set. So those are going to be dependent on which choice of tax-based system that you would like to take. And then there is this whole business of purchasing of healthcare services, where we are trying to move from more of a passive purchasing to a strategic purchasing. But then again, the question of purchasing is not limited to just saying that, I just contract with a healthcare provider and he starts providing healthcare services. That's not what purchasing truly means. A function of purchasing would then further have, sub activities or roles to be or details to be defined in terms of, what is the coverage, or in other words, for whom do you want to buy services? That means which population is the one that is entitled for the coverage. What are the type of services that you want to purchase? From whom do you want to purchase or buy these services? Is it going to be public? Is it going to be private? Is it going to be a mixed plural system? And then once you've done that, then how do you pay your providers? And then very, very important question, how much do you set those prices? That's again a very, very fundamental question. We keep hearing that in debates in the context of the publicly funded programs in India as well. And then finally, in the entire description of your health benefits package, how do you ensure that quality is maintained? So you can see that there are so many aspects of even the purchasing function. And then the provider payment, again, it's again a very, very complex system to understand in its own sense, because you're not just using one particular type of payment system. Your payment system could be determined based on the market structure, could be based on the time at which you are paying. Is it a prospective payment? Is it a retrospective after the service has been delivered? And based on that, you classify what is the method that you are using to pay your healthcare provider. And finally, it may also depend on what are the type of services or what are the type of healthcare providers that you're trying to engage with in order to pay those services for. So again, it's a complex decision-making kind of algorithm. You may end up choosing a mix of blended payment system, which may involve several payment options, depending on your context, depending on your overall objectives of the health system, and what is it that you want to eventually incentivize. So with this very broad overview of what the healthcare financing system, what is the need of it, what are the various functions of a healthcare financing system, you can understand that there are a whole range of applications that you could put this information to. And these are very, very broad brush applications that I've written right now on the slide. In practice, when you start to delve into it, each of these could be further stratified into perhaps 5 to 10 more sub bullet points. So you could apply this information for the purpose of budgeting. You could apply this for the purpose of pricing your healthcare services. You could use this for designing your strategic purchasing systems, for priority setting, defining what to include, what perhaps not to include. And finally, eventually, all of this to guide your decisions around allocation. So I'll stop here and perhaps let's make best use of this time for Q&A and further discussion. Thank you.
Thank you very much. Thank you, Dr. Shankar. So you indeed have captured the essence of health financing in like those 10 slides. So I'm sure there was so much of information that people have to revisit and rewatch this webinar, and this would be available on public domain through YouTube channel, because every slide or content on every slide require at least a 5 or 7 or even longer time. But you try to package that in a very synthesized way, succinctly. So thank you very much for all that effort. Like health financing, we always hear like 3 things: collection, pooling, and purchasing. And then you talked about multiple aspects. So thank you. Just for the audience benefit, I'm sharing that this information will be available, this video or this entire conversation will be available online. Before I go to the participant questions, I still want you to please elaborate on a few things. So people often get confused or often talk about health financing and health economics in the same breath. What is the difference and what is the similarity between the health financing and health economics?
Okay, so I think that I would say that health economics may have certain other domains, certain other functions, certain other principles, and financing would be one part of that. But typically, a health economist perhaps may also like to deal with questions around microeconomics, which may, for example, have applications in terms of making certain decisions. So, for example, here we talked about purchasing healthcare services, but whom do you purchase these healthcare services from? And we do have a very strong debate on whether we do go in for public provisioning, private provisioning. Now, principles of microeconomics help us to understand how do markets function, what are the kind of incentives, disincentives, what are the kind of perverse incentives that may come in with a certain type of provisioning. And then how to address those again becomes an important question. So microeconomics would go into, and also the fundamental question of, every time, every healthcare professional, public health professional, eventually at the end of the day is bombarded with just one question on his performance, and that is coverage. And this coverage is going to be then subsequently dependent on two things. One is the demand for services, and the other is the supply of healthcare services. So this microeconomics also helps us understand what are the determinants of the demand for generating demand, and what are the determinants of supply for health or healthcare provisioning. And somebody who has a sound knowledge of these principles of microeconomics and understanding the determinants of demand and supply would perhaps be also able to apply those principles to further ensure that you are able to improve the access to care, coverage of which eventually translates into the coverage of services. So again, that's an application that goes into more core public health function. And then the third area is around priority setting, where we also talk about looking at the efficiency of healthcare services, looking at the cost effectiveness of various kinds of healthcare services. So as a result, so what I'm trying to say is that health economics may have several other domains. It may also have domains around behavioral economics, which where we would try to understand how do people make decisions to either purchase or to access healthcare, and etc. And which has again implications in terms of how do you design your policies and programs to ensure that your programs, services, have a greater acceptability and uptake.
Thank you very much. So you answered that question, and the second question which I'm going to ask is you have also answered, but I'm trying to simplify it and more simplistic, and would like to hear from you again. People often again equate health financing and health insurance. Are they similar or different, and how? So are health financing and health insurance same or different?
Right, thanks. So again, I would say that health insurance is a part of healthcare financing. Healthcare financing is like your umbrella. And this healthcare financing may involve even financing for interventions, programs, services, which may or may not have an insurance function within that. Public financing of public health interventions programs would also be part of your healthcare financing. Setting conditional cash transfers, creating schemes like JSY, JSSK, etc. See, fundamentally, we sometimes roll out a program like JSY just by our own understanding that giving a cash incentive is going to improve is going to entice women to come to your health facilities and get their babies delivered there. But essentially, what you're trying to do is you're trying to basically play with the price that the individual consumer faces at the point of accessing the healthcare. And by giving that cash incentive, you're kind of reducing the price that the consumer faces, which is typically an application of microeconomics. So basically the health insurance is just a subcomponent of the overall subject of healthcare financing.
So in short, you are saying that health financing and health insurance are not the same. Health insurance is one of the tools within the broader framework of health financing. That brings me to the third question, which all of us keep hearing a lot about: universal health coverage and UHC. So many state government or many of the government launch a health insurance scheme, and then they start saying that they have achieved or started to do UHC. So this is the next question: is health insurance and universal health coverage synonym or different?
Again, I think I would say that the health insurance is one of the means to achieve universal health coverage, but it all depends on what you are providing through your health insurance. And typically, if we look at the Indian context, where the insurance is likely to, in most instances, provide coverage for hospitalization care, and that too for predominantly tertiary and to some extent secondary care as well, I would say that universal health coverage has several other components then to also satisfy, to also meet, which means that the entire domain of provisioning of primary healthcare is another fundamental bedrock of the strategies towards achieving universal health coverage. And having an insurance scheme adds on to the overall protection for financial risk, for the financial risks that individuals may incur when they seek secondary or tertiary healthcare services in a hospitalized setting.
Thank you. So essentially, if we go by the definition of universal health coverage, it talks about service coverage, population coverage, and financial protection coverage. So health insurance is one of the tools which will ensure financial protection coverage, to an extent service coverage and population coverage, but not the same thing. It's health insurance is one of the tools to UHC. Before I hand over to other members who are here, like our fellows who would ask questions, so please raise your hand. But before that, I have 3 questions. Like I picked 3 points from Dr. Prinja's talk, and I would request him to elaborate. So first question is that please, not question, like these are 3 terms which are commonly used in health financing. I request you to please elaborate a little more. First is a cream skimming. What is a cream skimming in health insurance? Second, what is moral hazard? And third, what is information asymmetry? So because you brought those points, so I would request you to please elaborate for benefit of wider audience. Cream skimming, moral hazard, information asymmetry. Thank you.
Sure, thanks. So basically, in the context of, let's say, voluntary private insurance, when you ask an insurer to insure individuals for their health care and charge them a particular premium, they basically know only a certain average population level risk that currently exists for people to fall sick. So let's assume that they are going to that at the population level, we know that self-reported morbidity, let's say, or morbidity rate is about 10%. So what the insurance company knows is that out of 100 people in the community, there are 10 people who are likely to fall ill. Now, they set a premium at a rate which is sufficient to meet the healthcare expenditures if only 10 people fall ill. However, when they go out and seek this as a contribution from people voluntarily, eventually what ends up is that the people who perceive themselves to be at a higher risk, who know that they are having a higher probability of falling ill, they are the ones who are likely to first get themselves insured. And this is what we call as adverse selection. So people at higher risk of falling ill are the ones who are likely to buy a voluntary private insurance. And as a result, the pool of individuals who buy an insurance may now collectively have a risk that of falling ill, which is not 10%, but which would be likely to be 15% or 20%. Now, this is not going to be viable for the insurance company at the premium that they set, assuming that 10% people will fall ill. So as a result, the company is likely to go into a loss. But the company also knows, and the insurance industry also needs to survive. So what they would do, and what they do as a result of preventing any adverse selection, is they also try to engage in identifying individuals who are relatively more healthier. So they would rather have certain exclusions, that the elderly are not included, or the people who are having pre-existing illnesses of a certain nature, we will not give them coverage, or the ones who are, let's say, who have a history of a cardiac event in the last 1 year, they will not be provided any coverage for a cardiac illness in the next 1 year of their buying the insurance cover. All of this eventually is cream skimming, because they're trying to take out the healthier individuals in the community and insure them. So this is again something that eventually leads to inequities, because you end up getting a pool of people who are either younger, more able to pay, richer, rather than the poorer and the sicker and the elderly, who are more likely to be at a risk of falling ill and less likely to have the resources to pay. So this is cream skimming. When you roll out an insurance program, and if your payment systems are such that So after your given insurance scheme has been rolled out, a person knows that he does not have to pay for healthcare. He may become frivolous in terms of using the healthcare. So even for earlier, he would not go for seeking healthcare. He will wait for a couple of days before to see whether his pain in the stomach subsides. But now, even with a skin rash, he wants to seek a specialist consultation. So this is what is a moral hazard from a consumer point of view. But then there is also a moral hazard at the level of supplier, because the supplier tries to oversupply healthcare services and induces a certain level of demand, which is the provider's moral hazard. And he tries to oversupply healthcare services for something that can be treated in outpatient setting. He would treat it in an inpatient setting because the insurance is only, coverage is only for a hospitalization, etc. So all of this is moral hazard, and this leads to overuse, overutilization, and eventually leads to inefficient outcomes of such a system. And the third point that you mentioned is around information asymmetry. The initial point that I mentioned about the insurance company knowing that the pooled risk of people falling ill is about 10% versus individuals knowing more. This is a kind of an information asymmetry at the level of an insurer and the person who wants to get himself insured. But there is another very fundamental level of information asymmetry that happens between the consumer and the provider. So the patient knows much little about the illness and what is the appropriate treatment than the provider or the doctor. And as a result, this patient completely places his faith on the patient, on the doctor, and the doctor takes the decision on behalf of the patient to perhaps make him better. Now, as long as the doctor takes that, and this is what we call as agency relationship. If the doctor is fair, if the doctor takes the best decision that is in the best interest, which is then there is no problem. But if the doctor or the provider, for that matter, tries to oversupply healthcare services, then this fallout of an information asymmetry leads to inefficient outcomes. And overall leads to inefficiency of the health system.
Thank you very much, Dr. Shankar. You really explained it really well and very simple language. So thanks. Nobody could have done better than this one, I can assure the audience here. So with this, I see some questions in the chat. One question is from Prajakta. Why don't you, Prajakta, you unmute yourself and ask this question rather than me reading this question. Prajakta, do you want to ask your question here?
Maybe I can go ahead. So, I think I can read it from a chat. So the question is that we know states have different fiscal capacities of health to spend. Is it possible to give more insights on that? So I think it's a very important point that you have raised, that states definitely have differences in the overall fiscal capacities, how much money they are able to raise. And that is why I think one of the points that I mentioned about at what point do you want to pool your resources, that becomes fundamental in this particular question. So if you let the resource pooling continue to take place at the level of the states, then it means that the poor states will always have a lesser amount of resources, whereas they may have a greater amount of needs. And as a result, pooling that takes place at the national level sometimes helps to ensure that there is some degree of risk equalization between the poorer states and the richer states. And in fact, this problem tends to be addressed at various levels by in financing decisions. So for example, when we talk about even the financial allocations of NHM, so while you have a per capita formula for allocating resources to each of the different states depending on their population size, but then you have a certain 33% higher allocation that goes to at a per capita level to the EAG states. That is essentially in order to bridge this difference between how much they're able to raise and how much is their actual need. So in order to make your vertical equity more reasonable, that's the kind of policy intervention that is done. But this is certainly a very, very important question. And this also brings in the importance of the role of the central government in this fiscal federal relationship that we have, where there is a level of risk adjustment that can be introduced by the central government, where it finds that the states may have a lesser capacity in order to meet their healthcare needs given their resources.
So there is another question from Vaibhav. Vaibhav, please go ahead.
Yeah, thank you, sir, for the opportunity. And hello, sir. That was a really insightful session, Shankar sir. Sir, I have a question regarding the Abha cards. So currently there is this dynamicity in the public health infrastructure, and with the introduction of Ayushman Bharat Health Accounts, and now there is these health records available at one click for all the healthcare providers. So my question is, sir, how these can be leveraged, these Abha cards can be leveraged, and the availability of these digital records can be leveraged to improve the services and the continuous provision of the various cash benefit schemes like PMM, this Matritva Vandan Yojana is there. So how these can be leveraged and it can be used to continue and sustainable manner we can provide these kind of services, cash benefit schemes to the population. So can you share some insights on that, sir?
Sure. Thanks, Vaibhav. I think you've raised a very fundamental question, but at the same time, you've also partly answered the question. So essentially, one of the very, very fundamental uses or the potential applications of this Abha card is to create this kind of a continuum of care, which we haven't so far been able to achieve in a very, very significant manner. So what I mean by continuum of care is a kind of an integration between your primary, secondary, and tertiary care levels, or the continuum of care that you expect across the different age groups or the age intervals through which an individual passes, etc. All of which is fundamental to the overall care delivery and care continuum. So Abha card, which is currently now being generated even by a CHO and an ANM at an HWC level, and also being created at hospitals through the patients that are, let's say, accessing the services of these publicly funded insurance programs. Now, if this is being recorded at both these two levels, this becomes one of the most fundamental, unique identifier of an individual who can be linked across these two continuums. So there can be always a mechanism of up referral whenever there is. So you have an Ayushman Bharat Health and Wellness Center, which is screening individuals, which is identifying people at an early stage to make sure that they don't fall sick. But at the same time, you might find somebody who may require a hospitalization, and this person could be referred up in the ladder of this healthcare system. And having an Abha card, having some kind of a system for up referral, could even maybe an information could be sent to these higher levels to ensure that services are delivered as the person reaches there. And similarly, we have so many cases that where a tertiary care or a secondary care hospitalization is required, but subsequent to that, there is a need for subsequent home visits, primary care, to ensure that the outcomes of this hospitalization are better. So you have a person who's operated for, let's say, heart valve replacement, but then subsequently he has to remain on anticoagulation. Now, if that anticoagulation is well monitored, is ensured that he continues to take medicines on time, or if there is let's say a CAD event for which a person has been hospitalized, but then he goes back, he has to at least maintain his blood pressure levels at an appropriate level. And this is something which is a duty of the primary care team. Now, once discharged from this level, if there is a subsequent contact and provision of services at the primary care level by the team through an exchange of information that takes place, or some kind of automatic alerts that are generated once a patient gets discharged here, using this unique opportunity of this identifier, which is Abha card, this is one of the most important potential benefits, I would say. And obviously, any investigations that you have done at the lower levels don't have to be repeated again at the higher level, because you have linkage of the health records. So the person at the secondary level or the tertiary level knows that what investigations have been done down below, and he does not necessarily have to repeat. Again, it leads to efficient outcomes.
Thank you, Dr. Shankar. Any other question from the audience? Please raise your hand, and this is your opportunity. We have some more time before we close this session. I don't see any hand. Yeah.
So
Yes,
sorry, I
Palak.
could not. Yeah. So thank you for the lovely session. My question to Dr. Prinja is about states which say that they have universal health coverage, like Meghalaya is one of them. So what does that actually mean? Like, is it about only, is it about covering the number of people, or is it also about covering the number of services? So although like Meghalaya, I'm still a little bit aware of, but I've been hearing that Haryana is providing universal health care. Is it even true, or what amount of coverage is being provided?
Right. Thanks, Prajakta. I think the achievement of universal health coverage is ultimately a journey. And we need to understand that it is eventually going to be a journey, and you will need progressive incremental steps to be taken in order to achieve the level of aspirations that we have set for ourselves. So in that direction, I think sometimes the most easiest thing for program managers, policymakers, etc., is to first have a commitment around population coverage. Then the next step along with that is to ensure that there is an enough basket of services which is sufficiently large enough to make sure that the kind of services that they need are likely to be met over the next, let's say, course of a year or so. And then you also try to ensure that they do not have to spend enough and all that. And between this entire journey from population coverage and service coverage to effectively ensuring that people do not necessarily spend a lot of money on their healthcare, you have to set a lot of systems and processes to ensure that the design that you have set for yourself does lead to the right outcome. So you might have said that you have a high population coverage, but then the network of your healthcare providers is not wide enough, let's say, and as a result, the people who have actually require care may even go to some other providers who are not empaneled, etc. So what I'm trying to say is that there is a lot of implementation level nitty-gritties, details, and challenges that have to be met in order to ensure that whatever commitments that you make in terms of either population coverage, service coverage, etc., to get eventually realized in terms of access, coverage, and financial protection.
Yeah, thank you, sir. Thank you for that. I mean, that's really, really insightful. So you have been with NHA for a while, and since PMJY has come, it's going to finish like 5 years. Do you feel there has been some amount of difference in comparison to previous schemes that we had, like RSBY? I'm not sure how RSBY was really performing, but it had a smaller scale. That's what I know. So what is your take on it?
Okay, good question, I think, and it's a bit of a spot that you put me into. But I think that, and it's a very fair, unbiased response that I'd give it to you. So if you look at the literature in terms of the impact evaluations that have been done for schemes prior to PMJY, given the design features of the scheme, that means how much was the benefit that these schemes offered and how much did these schemes cover in terms of population, etc. There are two very key findings that you get from all the impact evaluations, and it's a kind of a consensus. A, it improves utilization. Okay, all studies show it improves utilization. But again, majority of the studies show that there is either no impact on out-of-pocket expenditures or rather a contrary increase in out-of-pocket expenditures. And this is what studies during the RSBY or that period show, most of them. The PMJY, we have very little right now in terms of published evidence on impact of these schemes. However, whatever limited has come out, the evaluations are pointing to a direction that there is a definite reduction in out-of-pocket expenditures among those who are accessing among the beneficiaries of PMJY versus the ones who are not enrolled under PMJY, which is again a point which points to the fact that there is definitely a benefit of the scheme to reduce the out-of-pocket expenditures, which is something that we were not able to see in the earlier versions of the scheme. Now, this could be a result of several improvements in the design features, expanded, the height of the cube that you offer now, rather than 30,000, you offer a 500,000 cover, or the very significantly expanded network of empaneled hospitals, etc., close to about 26,000 plus hospitals that are part of the scheme. All of this eventually contributes, but there is still definitely, it's again, as I said, it's a journey, and it is, you would still need a lot of ground to be covered before we start to say that the people are not incurring any expenditure at all, because there might be certain services that are not covered maybe right now, or maybe certain services that eventually, because of low awareness, patients access in hospitals that are not empaneled, or they incur a certain expenditure before they actually get hospitalized because of the diagnostic, etc., that are done before a diagnosis is established and a treatment is initiated. So, as I said, there's a whole range of check boxes to be ticked before your design leads to the outcome, and this is your implementation. And I think the details lie here in this chain. But definitely, the early signals are pointing to a significant positive impact of the PMJY. And as we go, I think the learnings from the early stages of years of implementation would further help to refine the scheme design and its implementation.
Thank you, Dr. Shankar. So we are approaching toward the end of this session. But before that, there is one question which Namrata, who is coordinating YouTube audience, will ask. And if there is one more question from this group, then we will take 2 questions maximum, and then we will hand over to Navya for closure. So Namrata, first to you. You are on mute.
Thank you very much, sir. Actually, my question to you is, how an
Sorry, I think your voice was breaking. I wasn't able to get the question.
So, my question to you is, how an equity analysis financing?
Sorry, I heard till you said how an equity analysis. Then I lost it again.
Let me read this question to you then.
Okay.
So the question is how an equity analysis can be done with regards to health financing. And that's the exact wording from the audience on YouTube.
Mm-hmm.
So essentially the person is asking about equity analysis in context of health financing.
Right. So there are 2 ways of looking at equity. One way of looking at equity is in the context of access to care, and which we refer to as horizontal equity. So whichever attributes of population subgroups that you want to compare, whether be it income, be it caste, be it education, be it gender or region, you would like to stratify the levels of utilization of care across each of these population subgroups. And that becomes one of the ways to look at equity, which we refer to as horizontal equity. The other is that you analyze the levels of payments that people have made relative to their ability to pay. And this is relative to their either income or consumption expenditure or whatever. And this is essentially a measure of your vertical equity. And then there could be various indices that you could compute to determine this equity or to quantify this equity. And there is a whole range of literature around use of concentration indices, the Lorentz curves, etc., that you can refer to do this kind of an equity analysis. And then within financial risk protection also, again, you have certain role from an equity standpoint to evaluate.
Thank you very much, Dr. Shankar. So I don't see any hand. And if there is no hand, let me take this opportunity to thank Dr. Shankar for a really wonderful presentation. Yes, Navya.
So there is one more question on YouTube.
So
it's from Dr. Gaurav Jha. What about private setup? How can government mandate the private institutes to comply to ABHA IDs?
I think it's a question that goes definitely much beyond the scope of the current talk. However, just to very briefly respond to that, I think that there are two ways of making sure that the private providers comply with the kind of digital architecture that is being put in place. And essentially in policy, we say that you have to basically both use a carrot and a stick. So a carrot would mean that you need to really show the value of the digital architecture. What does it mean and what does it bring to those private players? So generating the kind of use cases and the value of that to the providers is perhaps the first thing. And second is obviously, you could also create a certain level of incentives. You could build in certain incentives with the creation for adoption of the digital architecture. One of them could be, for example, let's say the empanelment for a publicly funded insurance program could be linked to creation to being complying with these Aadhaar IDs, or you could give further monetary incentives for hospitals to, if you believe that they are going to be incurring certain extra costs to complying with those standards, etc. So those are some of the strategies, but I think there's a lot that the Ayushman Bharat Digital Mission is trying to do in order to meet all these in order to respond to these requirements of the private sector to come on board and be part of this journey of the ABDM.
Thank you, Dr. Shankar. So let me take this opportunity to thank you for joining, sharing your reflections, responding to audience questions. This was, in my opinion, very informative session. This is the first one in the 3-part series. And we also hope that you would be able to join for the subsequent panels also. And in the meantime, if the audience and some of the questions which comes on YouTube, we will definitely keep those questions reserved for you to ask in the next session. So I thank you, Dr. Shankar Prinja, and hand over to Nabya for the closing.
So thank you everyone for joining. Thank you, Dr. Shankar Prinja. Thank you very much. This is very informative session for all. And at last, I just want to request everyone to just for the photo, I need you to open your screen, like video, so that I can take a screenshot. I'm requesting everyone to just switch on their camera. Just one more second. Yes, done. Thank you so much, everyone.
Thank you very much.
Thank you very much. Bye-bye.
Bye. Thanks.
Thank you. Good night.